Welcome to another EduMed video, and in this airway pressure release ventilation video series we're going to be talking about how to set the pressure low or the low pressure in APRV. We'll again go through a little bit about what APRV is, then how to set the P low, and finally a few cautions with regards to setting P lows, especially in ventilators that are not intensive care ventilators. Before you watch this video, I'd really highly recommend you watch my basics videos on ventilation. There's a whole series of them on my channel. The really important thing that I keep emphasizing with any ventilation video is to look at this particular picture. Have this in your mind, and everything that you do to optimize a patient in terms of their oxygenation and CO2 removal boils down to this simple picture. All you need is the alveolus to be open and therefore be blood flow going around that alveolus to allow gas exchange to occur with the blood. APRV itself is really termed extreme CPAP. What you really want to do is to try and accrete up as many alveoli as possible for as long as possible. So people term it extreme CPAP because at its very basic, all it is a very high pressure to open up all those airways. And that'll help with oxygenation of the patient, because the longer the alveoli is full and open for, the more oxygen diffusion will occur over a given period of time. Oxygenation itself depends upon the inspired fractional concentration of oxygen, but also with the alveolus being open, thus keeping it open for as long as possible with the high pressure or the P high. It depends upon alveolar blood flow, so we do need to make sure that we optimize right ventricular outflow and cardiac output in these patients. And the alveolar blood interface can only really be improved through treatments and time. So things like diuretics, antibiotics, anti-inflammatories really do take a bit of time. So APRV is there to give us time to allow for the treatments that we give in intensive care to actually work. Carbon dioxide, generally speaking, depends upon the minute ventilation on a patient, so the bulk movement of gas in and out of the lungs. And that's dependent upon the tidal volume and the respiratory rate of the patient. Again, as with oxygenation, alveolar perfusion is key. It's 50% of what happens in the lung is ventilation, so the movement of gas, and the other 50% is the blood flow. And it's the matching of both the ventilation and the perfusion that is key to having efficient ventilation of a patient and good management of carbon dioxide and oxygen levels in the blood. Carbon dioxide removal in APRV also has a second facet. So in addition to that bulk movement of gas, that's really a function of the minute volume, you can also allow for gas to slowly diffuse from an area of high concentration. So for the carbon dioxide in the alveoli, it'll have a high concentration, to an area of low concentration, which will be at the ventilator side. So actually, you may get even more efficient CO2 removal in patients with APRV, because you're utilizing the notion of diffusion much more so than with conventional ventilation, where lung units open and collapse continuously throughout a respiratory cycle. So as we said, at its core, APRV is just extreme CPAP. It's just allowing the patient to breathe up on a much higher pressure that allows more of the alveolar units to remain open. But what's the problem with having just the lungs open all the time? Well, the problem is that you don't have bulk flow of gas. If a patient is breathing up on CPAP, generally speaking, they have decent tidal volumes, but in APRV, what often happens is you started it because the patient is critically unwell with severe respiratory failure. And as such, the amount of gas being moved in and out of the patient's lungs through their spontaneous breathing is often not adequate, especially given that they're mostly hypermetabolic with an inflammatory process going on, and therefore their CO2 production is even higher than normal. As such, we need to find some way to remove the CO2 from the lungs, in addition to just awaiting diffusion of the CO2. And this is where the pressure releases come in APRV modes. And this talk will be talking specifically about what to set as your pressure low. And the pressure low is the pressure that you drop it to every so often after you've hit the end of your high pressure time, i.e. your T high. This is just a slide to summarize the different things that can be set, and the one that we're going to be focusing on in this particular video is the P low. So how do you decide the P low? It's really simple. Always set it to 0. Now some of the ventilators, for whatever reason, they don't always allow you to get down to 0. Some of them only say 5. But whatever the lowest setting you can get is, choose that. Now you might question, well, if I drop it down to 0, surely I'm going to lose the recruitment. If I'm letting the high pressure release down and it goes from a pressure of say 30 at P high or pressure high down to 0, then that's all of it lost. And what about the PEEP? What about maintaining that recruitment? Well, the interesting thing about APRV is the way in which you maintain the lungs recruitment and you maintain the pressure within the lungs is not through the P low, but actually through the time cycling. Now this will be much clearer in the next slide. So let's take it right from the start. You've got a P high there, looks about 15, and it's set there, and then suddenly you get that release. Now what the ventilator is saying is, right, I've got a pressure of 15, 15, 15, and then when it gets to the point of the end of the T high, the release phase, it's going to go from 15, and then the ventilator is going to go down to 0. So it's quickly dropping down to 0. So you can see there the blue line, that's the pressure in the ventilator, is trying to drop down to 0. And the way to think about that is if you're driving a car, you've put the accelerator to the floor and you're accelerating as hard as you can. That's your P high level, and you're accelerating. And then what you're doing with the P low is you're telling the accelerator to come right off. Now if you pull the accelerator right off and then slam on the brakes, for example, you're not going to come to a stop straight away. You're going to start to slow down. And then if you slow down for say a minute, of course you'd come to a stop. However, if you only slow down for a fraction of a second, which is all we have in APRV, the time that you're at that low pressure is usually between 0.3 to 0.7 seconds, so less than a second. You haven't allowed enough time for the pressure to completely drop in the lungs. So by having just that short period of time, you're controlling the amount of pressure that you maintain in the lungs through purely the time limit that you're dropping it through. So why drop it to 0? Well, if you think about it, what you want to try and do is to remove as much gas as possible, as quickly as possible, before you get the pressure back on and re-recruit all of the lungs. And this is why you have the biggest pressure differential. You want to go from the high pressure down to 0, because gas will always move down a pressure gradient. The bigger the pressure gradient, the faster it'll drop. So if, for example, you go from a P high of 30 down to 0, that's a 30 centimeter drop in pressure difference. So there's going to be a big flow of gas coming out. If you go from 30 to 10, now rather than it being a 30 centimeter water pressure drop, there's only a 20 centimeter pressure drop. So the gas is going to flow out that much slower. So it is always more efficient to have the P low set at 0. And then if you feel like the alveolar units are starting to collapse, that you're not maintaining that recruitment, you want to shorten your T low, so the time that you've got it at that low pressure for, to try and optimize maintaining as many alveolar units open for as long as possible. So this is a time cycling method of maintaining the pressure inside the lung. And the pressure inside the lungs, you can see, is this dotted red line. It is not the same as what the ventilator is giving in terms of pressure. because it's not allowed enough time for the pressure in the ventilator to equalize with the pressure in the lungs. So you'll see this with a lot of my slides. This is just the typical settings for the average patient that gets started on APRV. And you can see here, the P low or the pressure low is set at 0 centimeters of water for all patients. It is worth just highlighting a couple of cautions. What would you do if you increased up the P low? Well, as we said before, if you increase it up to 5 or 10, you're going to decrease the pressure differential between the lungs and the ventilator, and therefore you could potentially make the removal of CO2 that much less efficient, and so you could get your PCO2 starting to rise up. And you often see this because nurses and junior doctors who aren't used to APRV might think, oh God, why have we set a P low of 0? Everyone should have a bit of PEEP, without really understanding that it's a time cycling that's maintaining the pressure inside the lungs, not the pressure that you set at the ventilator. And so always check what's been set. You'll be surprised how often people just fiddle with the ventilator when you walk off, and therefore make things worse. And it will make APRV less efficient, especially for CO2 clearance. There are a few occasions where you need to think about having a higher P low, and that is where you're using a ventilator that is not an intensive care ventilator with an APRV mode. If you're trying to use other ventilators like a transfer ventilator or an anesthetic machine ventilator, they don't have as efficient valves, and so they're not able to open and close their valves as quickly and as efficiently. And as such, you may well need to have a small amount of P low, or PEEP is usually what those two ventilators will be set at 5 or 10, just to maintain some alveolar recruitment. But be aware that by doing so, you are going to reduce the efficiency of CO2 clearance. So in summary, P low, or the pressure low, is always set to the lowest it can be, usually 0. In some ventilators, they only go down to 5. If you're not using an ITU ventilator, it is worth considering using a slightly higher P low of 5 or 10, and just accepting the slightly higher CO2 that the patient may have, simply because the valves just are not as efficient and not good enough to be able to provide APRV-like releases to maintain pressure within the lungs and to maintain recruitment of lung units. I hope you found this video useful. If you have, please like and subscribe to the channel and hit the bell notification, as there's going to be lots of videos coming out in the preceding months on APRV and other aspects of intensive care treatment. Thank you, and see you next time.